Okay, it's 6:05, so I think we'll get started. There's a pretty good crowd in already, and I'm sure some people will be admitted as I'm making our introduction here. So, good evening, everyone, and welcome to tonight's edition of the Oak Seminars in Contemporary Periodontology, presented to you by the Graduate Periodontology Program at the University of Toronto. We had our inaugural lecture last week, and we were enthralled by a lecture by our very own Dr. Jim Lai, former head of the discipline, now vice dean at the University of Toronto. Excellent turnout, excellent response to his lecture. And for those of you that couldn't attend, the link to this lecture will be on the University of Toronto Continuing Dental Education website, and it will be featured on the YouTube channel for the Faculty of Dentistry. For those joining us tonight for the first time, again, warm welcome to you all. This is a really interesting time that we're all living in, and so it's nice to be able to connect with people in these platforms. To give you a little idea of what these Oak Seminars are all about, the oak tree is the symbol for the University of Toronto. It is a strong tree with a solid foundation that supports growth, essentially reaching for the sky. And perhaps no discipline in dentistry embodies that better than periodontics, as periodontics really is the study of the foundation around the natural dentition, and even more so now around dental implants. And so the objective of this seminar series is to present topics of relevance in the field of periodontics and surgical implantology, presented by international speakers, as well as those recognized experts that are even from our own very own local community, for the purpose of bringing the U of T community together, as well as the broader dental community at large. Just going to advance my slide here. We have 3 speakers lined up that'll take us to the end of the year. On November 16th, we have Dan Cullum, who's an oral surgeon from Idaho, who'll be talking about deepithelialized amnion-chorion membranes for minimally invasive surgery. Then we have our very own Dr. Michael Goldberg, who'll be speaking about his work on the diagnosis and management of peri-implant diseases. And then last but not least, to end off this year, we'll have Dr. Salah Huwais, who's widely known for his innovation of osseodensification. Of course, putting a seminar series like this is not without the hard work of a number of individuals, and I'm truly blessed and grateful to be a part of this committee of individuals. And I just want to take a moment to introduce everybody, starting from the top left. We have Dr. Alexander Hunter, then we have Dr. Chris Swayze, Dr. Doug DePorter, Dr. Nancy Balden, Dr. Quinn Chang, and myself, and then of course our amazing chair of our discipline, Dr. Vanessa Mendez. The majority of the lecture, you have to attend the majority of the lecture. Some housekeeping here. You have to attend the majority of the lecture tonight to be able to get CE points. And if you have a question that you have a burning desire to get an answer for, please enter it in the chat box to one of the the moderator, and all questions will be taken at the end of this presentation. Now, on to the main event. It is really my pleasure, really an honor for me to be able to introduce Dr. Douglas DePorter, who will be speaking to us tonight about PRF, CGF, and their value in regenerative oral surgical procedures. Doug is a longtime professor at the Faculty of Dentistry, University of Toronto, and pretty much anyone who's gone through the program over the last 40-some years has been the beneficiary of Doug's teachings. He is a clinician, he is also a scientist, and has been a pioneer in the use of short and ultra-short dental implants, a subject that he's recently written a textbook on, amongst many other publications that he's had to his name. He's focused a lot on minimally invasive surgery throughout his career, and he's an icon. He's a legend in the world of dental implants. He's lectured nationally and internationally, and has been a mentor of mine over the years. So, without further delay, Doug, I'm going to unshare my screen and let you take the stage.
Okay. Good evening, ladies and gentlemen. It's a pleasure to be with you this evening. I've been asked to introduce myself, and I like to describe myself as a serendipitous academic because I didn't intend to be an academic originally. It just kind of fell into place. When I graduated, I went to the University of Chicago for an internship, and then I applied for perio because I didn't know how the devil I could manage patients with periodontal disease. And just by chance at the time, the Medical Research Council of Canada was offering a special fellowship to train academics in dentistry. And so I fell into that program because they invited me and I couldn't say no, I guess. And that led over the years to a PhD and studying abroad in England in mechanisms of inflammation and so on and so forth. I've always been looking for innovations in dentistry and innovations that are basically supportive of minimally invasive treatments. And so I was really fascinated by this concept of platelet-rich fibrin, which is the topic of this evening. Now, it used to be that we thought that platelets basically were meant just to stop bleeding. Of course, they do that naturally. We need platelets to stop hemorrhage. But platelets in the last couple of decades have also been shown to contain and release a large number of potent growth factors. So in fact, they don't just stop the bleeding, they begin the reparative process, okay? They enable fibroblast progenitors and osteoblast progenitors to heal wounds.
Sorry, Dr. DePorter, your screen is not being shared.
It's not being shared. Oh. Okay. Share. Oh dear. Share the screen. Oh, share the screen. Is it being shared now? Hello? Oh, dear.
Yes.
Let's go to presenter mode.
Okay, so it's being shared now, right? Okay, so I'm talking about platelet-rich concentrates. And there basically were two generations. The first generation was called platelet-rich plasma. And that was basically first reported by a neurosurgeon, Dr. Marks, in the early 90s. But more recently, we have been talking about platelet-rich fibrin, okay, which is the second generation, and as you'll see is much easier to work with, and it is certainly useful in private practice. Now, Marks, as I said, Robert Marks was the person who introduced platelet-rich plasma way back in the early 90s. And he described, in this paper in 2001, he described the properties of the first generation, including disadvantages. The first generation plasma preparations could be obtained in hospital operating rooms only, and that was done by plasmapheresis using expensive medical laboratory cell separators, dense gradient density cell separators. It required up to 450 mils of whole blood, which is gathered by a catheter. Plasmapheresis, of course, being the process of isolating plasma and platelets, and then returning the other blood components to the patient's circulation. So it was something that had to be done in a hospital waiting room, and therefore was not widely usable and was expensive. It also required double centrifugation and the addition of exogenous coagulation factors, such as calcium chloride and bovine thrombin. And there was the concern, of course, that bovine thrombin might introduce some disease implications, such as mad cow disease, for example. It was a liquid phase, so it was difficult to localize and handle. It had a very short release of the growth factors from platelets, and the impact was unpredictable. So you'll see publications from the early work in platelet-rich plasma where some clinicians were highly supportive of the use and noted that it produced significant impact, and others said, well, it's not really much better than controls. And this was basically because of the difficulty in localizing the liquid forms. And this is now the recent generation of plasma preparations are called platelet-rich fibrin, okay? And they allow you to prepare platelet isolates in office using a simple procedure. It's a single centrifugation procedure, and you don't need to add exogenous coagulation factors. And what you end up with is a fibrin clot, which is rich in growth factors and leukocytes. And it forms spontaneously when it makes contact with the surface of a glass tube, a glass blood collection tube. The result is a 3D scaffold of fibrin, which has a lot of platelets, of course, but also encourages the ingrowth of cells such as PMNs that have an antibacterial effect, and fibroblast precursors, osteoblast precursors, and of course initially it facilitates angiogenesis, or the development of new capillaries in the wound. And another advantage of the second generation, that is the PR platelet-rich fibrin, is that growth factors are released slowly. And so they can have an impact for up to 10 days following introduction into a surgical site. There's a couple of books you might like to reference. One of them is the one originally by Marks and Agarg, which was describing the first generation of the platelet-rich plasma, and more recently, a book by Richard Miron and Joseph Shukran basically outlines the advantages of the second generation platelet-rich fibrin in regenerative dentistry. So basically what you do is you draw blood into two types of tubes. Number one, you have glass red cap tubes, and they have no additives. And so as soon as the blood hits the glass and it goes into the centrifuge, you have the formation of a tri-layer, which is the top layer is the fluid, straw-colored fluid, which is basically platelet poor plasma, plasma low in platelets. In the middle layer, you have your fibrin clot, which is full of platelets and leukocytes and even some stem cells. And then at the bottom, you have your red cell thrombus. Okay, so after centrifugation, you withdraw the fibrin clot from the middle. It's attached to the thrombus. You cut off the red cells, and then you have this nice little fibrin clot to use in your regenerative surgical procedure. Now, the most widely studied platelet-rich fibrin so far it's called LPRF, and that stands for leukocyte-rich platelet-rich fibrin. Okay, and the person who introduced that originally was Dr. Shukran, who actually, as you can see, it was introduced in French because he is a French physician. And he collaborated with a lot of other individuals, such as Dr. Doan and Dr. Pinto and others. So you'll find mostly that the literature relates to LPRF. And this is one of the first papers that were published on the benefits of LPRF was by Dr. Nelson Pinto, who comes from Chile, and in combination, working together with Dr. Doen, who at that time I think was in Switzerland, and Dr. Quirinen and his colleagues who are in Belgium. At any rate, they showed that platelet-rich fibrin clots, LPRF, was very beneficial in healing chronic diabetic ulcers. All right, so basically you take your fibrin clots and you can apply them to a diabetic ulcer, leg ulcer. So here you see the sequence of a long-standing ulcer, which was cleaned up, and then LPRF clots were applied. You see the following 2 weeks and then reapplied at later times. And over the course of 3 months, the chronic non-healing ulcers have healed. So that was a remarkable contribution to the field of diabetes. So I mentioned LPRF, but there are lots of other names that have been assigned to PRF preparations that have been proposed by different individuals and even different companies, okay? And it's been quite confusing. The terminology has been quite confusing. So there's a recent paper by these gentlemen, and they basically point out that PRF is the generic name for the family of platelet-rich fibrin clots, okay? This is as a result of placing venous blood into glass centrifugation tubes, introducing it into a centrifuge, and having endogenous coagulation happening. The original PRF came from Dr. Chukrin in France, and he and his colleagues called it leukocyte and platelet-rich fibrin, which is LPRF. At about the same time, there was a Professor Seco in Italy who refined the procedure in terms of the type of centrifugation forces that could be used. And he termed rather than LPRF, he termed his concentrated growth factor, or CGF. In the meantime, Dr. Chukrin seems to have split up from some of his previous colleagues and has introduced a new term called APRF, which is advanced PRF, and he even has something called advanced plus PRF. But basically these different names come from the different individuals who introduced the procedures and the different types of centrifuges that were used to create the CGF and PRF clots. So, for example, recently, Chukrin and others had proposed this advanced platelet-rich fibrin, or APRF, which is the original LPRF was done at high centrifugation forces, whereas the APRF uses low centrifugation with low relative centrifugation forces. They claim that this is somewhat better than the LPRF, original LPRF, but basically the jury is still out on that. And you need to realize that the quality of the PRF depends on the centrifugation process, the rotor angulation, the programmed RPMs and associated centrifugation forces, the rotation time, any unwanted vibrations of the centrifuge, the room temperature, and all kinds of things will have an impact on the quality, the weight and density, and platelet content of the PRF clots that are formed. So, for example, Dr. Chukrin has introduced a new centrifuge for this low centrifugation process and the production of APRF. And he actually started a company now that sells these centrifuges, okay? The original LPRF, which of course was Dr. Shokran's originally, that was produced by a centrifuge that was originally produced in Florida. And it was called Intraspin. And you can still buy that because, as I said earlier, this is the most common PRF used. And then the CGF, the one that came from Italy, Professor Seco, that is produced using a centrifuge produced in Italy. And they all differ in their centrifugation criteria, factors. Now, in terms of the APRF, you see Dr. Doan was originally with Dr. Shokran, and he seems to have stuck with the LPRF and recently published a paper purporting to show that APRF clots were smaller, significantly smaller, and less stable, and more easily lysed than the original LPRF clots, and that they had weaker impact of growth factors. But this may change with time. Certainly, there's a lot less evidence out there at the present time for APRF than LPRF, and the majority, as I said earlier, of individuals who published have used LPRF. But CGF, the concentrated growth factor, and LPRF basically have shown similar properties. So you have the French versus the Italian, and since I'm a little bit of an Italophile, I have opted for Seco's preparation, largely because of a colleague of mine, Professor Son from South Korea, was very big in using CGF to begin with, and he actually introduced the concept of sticky bone, which we'll see in a moment, that Dr. Lai used last week in his presentation on predictable lateral augmentation. The CGF is what we'll be talking about, is basically what we have the most experience with in our department. It's produced by a centrifuge that's available from Italy, and it has a sequential series of centrifugation steps. It starts out with a 30-second acceleration, then it runs for 2 minutes at this G and 4 minutes at that G, and so on and so forth, and then a deceleration phase. And Dr. Borsani and others have shown that CGF basically has the same platelet-rich growth factors as LPRF, and even others have shown that there are some stem cells in the CGF, just like there are in the LPRF. So the key components of the platelet-rich fibrin that we're using, the LPRF or the CGF, is that it forms a stable fibrin scaffold, which supports the ingrowth of endothelial cells, revascularization. It also attracts PMNs, which have an antibacterial effect. It has a high concentration of platelet-derived growth factors, at least 4 times of normal, that's in normal blood. And also there are leukocytes, which contribute both an anti-inflammatory and antibacterial properties. And here's a list of many of the growth factors in CGF and PRF, LPRF. Now the key with producing either of these platelet aggregates is a fast blood draw, okay? So you're using a butterfly. You want to take your blood and have it into the centrifuge within 2 minutes. So quick handling is essential, or else you'll get early clotting and inadequate production of your aggregates, your isolates. Now, if you're new to drawing blood, you can look at something like the Vein Light, which is a little appliance that you can buy, which helps you identify where blood vessels are, identify them, and then allows you to have better vision of entering the vessel at the appropriate level and drawing venous blood. So in our case, following Dr. Seiko's and Dr. Son's recommendations, we have the red top glass tubes, and we also have yellow tubes or white cap tubes, which have a citrate coating in order to discourage coagulation. All right, so the red tubes, the glass tubes, have no coating, and you'll get spontaneous clot formation. The yellow tubes, you'll have a delayed coagulation because of the citrate lining. And to prepare the, we'll call CGF, which is concentrated growth factor, but the red tubes, as you can see, have the three layers, the poor plasma, then the clot, and then the red blood cell pellet. The yellow tubes have only two layers. They have this straw-colored layer on the top, which is basically a liquid fibrinogen. We call this the autologous fibrin glue. And so the autologous fibrin glue, by the way, that's this straw-colored fluid, is what they're using in sports medicine. So basically, with the yellow cap tubes, you have your platelet-poor plasma on the top, then you have your platelet-rich plasma with a few stem cells and a lot of leukocytes, and then you have a red cells at the bottom. And so you, for sports medicine, they draw off this platelet-rich plasma and inject it into problem joints. So for the AGF, that is the autologous fibrin glue or liquid fibrinogen, as I said, we're going to spin for 3 minutes in a yellow capped citrate coated tube. Whereas with the, we're going to produce our CGF clots with a 12-minute spin, at least that's what is recommended with the Italian centrifuge, in order to produce the clots. So we get the blood into the centrifuge as fast as possible. And when we withdraw the tube, the red tubes, red cap tubes, you see we have this fibrin clot, which comes out attached to the thrombus, okay, the red cell portion. And then you snip it off at the interface, trying to keep a little bit of red cells, because this is where the stem cells are, right at the interface, and where most of the platelet activity is. So you see here we retain a little bit of red cell from the interface. The key points in the preparation are, first of all, you get the blood quickly. You'd like to have the blood in the centrifuge within 2 minutes. You don't shake the tubes. You have your yellow cap tubes for the liquid fibrinogen or autologous fibrin glue, and you spin those only for 3 minutes, right? And then you withdraw those tubes and use them as I'll show you in a moment. The full cycle spin then is for the red cap tubes. So we, after removing the yellow cap tubes, we just continue the centrifugation with the, to complete 12 minutes of centrifugation time for the, in order to create the CGF clots. The sticky bone, which Dr. Lai referred to last week, is made with the autologous fibrin glue, and that's done very quickly, as we'll see in a minute. Whereas there's no urgency to use the fibrin clots. You can leave them sitting for as long as you need to. There are silica-coated plastic tubes, that's glass-coated plastic tubes, versus full glass tubes. And it's recommended basically that you use the full glass tubes because the silicone can come off. For example, this paper by Tuccino showed that amorphous silica particles can come off and be contained within your CGF or PRF preparation. Now, factors that affect PRF or CGF, first of all, the patient's current hematocrit. Sometimes, very oddly, we find that when we spin down the blood, we have this huge red blood cell clot and a tiny little platelet-rich fibrin clot. Fortunately, that doesn't happen too often, but that would indicate that the patient is very high hematocrit, and maybe you should be suggesting that they visit with their doctor to have some blood tests done. Cigarette smoking, definitely chronic cigarette smoking has a considerable negative influence on LPRF and CGF, both in terms of platelet size, platelet activation, and even the density of the fibrin fibers. Aspirin and other anti-inflammatories, they'll have a negative impact on your PRF clot. So if the patient is taking 81 milligrams of aspirin every day for cardiovascular reasons, maybe it's a good idea to discontinue that, if it's possible, for a couple of days before you draw your blood, in order not to have negative impact on your CGF clots, your PRF clots. So other things, of course, anticoagulants will affect the quality of your CGF clots. Statin drugs may do that. Antidepressants, well, certainly antidepressants have been shown to have negative impacts on implant outcomes with implants on some occasions. Maybe that's because of a negative effect on platelets, we don't know. Alcohol, usually we suggest that people abstain from alcohol for at least 24 hours before we're drawing blood to create CGF clots. For patients who are undergoing anticoagulant therapy, can you develop PRF clots from them? Yes, you can, but these individuals have suggested that we should have an increased centrifugation time from 12 minutes to 18 minutes. So there you go. And even something like a dietary influence. For example, if a patient's had a high-fat meal in the previous 24 hours, they could end up with this cloudy CGF clot or PRF clot. It should look like this, almost, well, like a clear gel almost, but this is very cloudy, probably impacts. We don't know the negative impact of this on wound healing, but certainly it needs further investigation. So let's talk about the benefits of platelet isolates in dentistry. First of all, we have our AFG, our autologous fibrin glue, or liquid fibrinogen. We can use that to prepare sticky bone, which turns the bone graft particles into a much more manageable state. We can use it as a fibrin glue. We can use it to coat implant surfaces with platelet-rich growth factors. And more in dentistry, of course, certainly in Europe and Korea and even in the US, dentists are getting involved in facial cosmetic improvements, such as, reversing signs of aging, nasolabial fold enlargements, deep wrinkles, and so on. And you can use this autologous fibrin glue for that purpose as well. Maybe we'll touch on that towards the end of the presentation. Anyway, to prepare sticky bone, we're going to withdraw the, we're going to first of all use the yellow cap tubes or white cap tubes, they're the same. And we're going to recognize that the top layer, even though this is one all straw-colored fluid, the top portion, let's say a millimeter or so, is platelet poor plasma. So we probably should draw off about a millimeter and discard it, and then take the rest of the straw-colored fluid with an 18-gauge syringe, 18-gauge needle and syringe, and we want to basically approach the interface between the red cell clot and the straw-colored fluid and draw off that portion of the straw-colored fluid, hopefully without any contamination from red cells. So we're going to withdraw the AFG, the autologous fibrin glue, with an 18-gauge needle. We're going to withdraw it carefully so that we don't contaminate with red blood cells. We're going to avoid red blood cell pickup. We're going to add the AFG immediately to the allograft or xenograft particles in order to produce our sticky bone. And within the course of 5 to 10 minutes, that will become a gel, as you see here in the upper right portion here. This is from one of Dr. Sohn's presentations. So we use the autologous fibrin glue, the straw-colored fluid full of platelets and leukocytes, to create this sticky mass of particulate material, which then can be very easily manipulated in augmenting around implants or doing augmentation procedures, as was done last week in Dr. Lai's presentation. This is a low 2,000 times magnification SEM of a fibrin clot, but remember that it's full of platelets and it's full of white blood cells. Okay, so there's where the benefits are coming. The fibrin gives you a scaffold which can retain the and slowly release the platelet-derived growth factors, and of course support the leukocytes, contain the leukocytes, allow for ingrowth of vascular tissue and other cells as well. So here's the Stickibone being applied to augment the buccal of 3 recently placed implants. You can see you can pick it up with a forceps or with a spatula. It's very easily manipulated. Now then we can use the CGF clots, that is the result of using the red-capped glass tubes to create these actual clots that we can then compress. So we can compress them in it's called a PRP box. So basically we place the clots on the stainless steel platform, and then with this stainless steel lid, which is heavy enough to compress the clots into membranes. Now, platelet-rich fibrin preparations, including CGF and PRF, have been shown to have antibacterial properties. So that's another benefit in using them in regenerative surgical procedures. This is a work from Italy in which they've shown that in vitro and in animal studies that it's a bacteriostatic rather than a microbicidal impact. So it doesn't have the same impact as an antibiotic, but certainly it likely reduces the need for antibiotic usage in a lot of regenerative procedures. Okay, so our CGF, we talked about the autologous fibrin glue in producing Stickibone. Now, the clots can be used for other purposes. So, for example, we can use them to reduce dry socket. You know, I would imagine that a lot of you are in the habit of removing third molars, and sometimes you can get a dry socket. This systematic review and meta-analysis done and published a couple of years ago showed a dramatic reduction in the incidence of dry socket, showed faster socket healing, reduced postoperative pain and swelling. So that's an interesting application for GPs and for oral surgeons, anyone who takes out third molars, those traumatic procedures where dry sockets often occur. It's also been shown that platelet-rich fibrin clots can reduce the risk of developing osteonecrosis in patients who are taking bisphosphonates and similar drugs that impair bone vascularization. And there's even a couple of case reports in this presentation from 2018 where they used CGF clots or PRF clots to help to treat established osteonecrosis. We can use CGF clots to help to control bleeding in patients taking anticoagulant therapy. Next then is socket preservation grafting. Now I remember years ago we introduced socket preservation grafting in our graduate department, our graduate division. I just put up this paper because it's a good review of surgical protocols for ridge preservation after tooth extraction. We want to preserve as much bone after tooth extraction so that hopefully we can, if the patient so desires, we can place an implant without much further augmentation grafting. So ridge preservation procedures result in significantly less vertical and horizontal alveolar ridge shrinkage. They generally are done using a graft, a particulate graft, in a barrier material such as dense Teflon, cytoplasm membranes, as you see here. But more recently, individuals have been suggesting that we could use the LPRF or CGF clots as a graft to minimize ridge loss, bone loss after tooth extraction. So in this paper, for example, ridge measurements were made with cone beam CT scans post-operatively at the time of extraction and 4 months later. They basically used the PRF clots as their graft material, and they suffered relatively minimal amounts of bone loss in terms of buccolingual ridge width. But the problem with that study was there were no controls. Terriman, who was originally associated with Chukrin, used leukocyte platelet-rich fibrin clots in a randomized control clinical trial looking at the impact on reducing ridge shrinkage. And you can see here they packed in the clots, then they flattened other CGF clots so they could use those as a double membrane over the socket. And then there's no need basically to get primary closure. You just have to stabilize the wound edges with the suture, and you can leave the CGF clots exposed. They followed up in 3 months with the second CBCT scan, and they noted significant differences in width reduction between the tests, that is the ones that received these fibrin clots, versus the control. So we had almost a 50% shrinkage in buccolingual ridge width with the controls, that is with the routine healing of sockets without any grafting being done, whereas there was half of that amount when the platelet-rich fibrin clots were used as the only grafting material. So you can see this in this graph from their presentation that basically 1 millimeter below the alveolar crestal bone, with the control sites, we lost basically 50% of our buccolingual width, whereas in the test sites with the platelet clots as the graft, we have substantially less, about half that ridge shrinkage. Now, this is an interesting paper where the authors have looked at the impact of platelet-rich fibrin clots on bone growth. They created critical size defects in rabbit calvaria, and then they used either no graft, that is the control, or they used LPRF or a CGF clot, and they found that after 6 weeks, in the no graft site, of course, you just have fibrous tissue ingrowth. You don't get a healing of the critical defect, whereas in the with the LPRF or CGF, you got complete bone healing. So there is, in fact, a stimulation of osteogenic progenitor cells and bone formation with some of the growth factors in the clots. However, as I said earlier, there's all kinds of different impacts that can affect the quality of your CGF clots, like aspirin and smoking and all those things. And so there have been some negative reports where controls did as well as the CGF clots or PRF clots. But basically, we need more study. And it's a very interesting and straightforward management for the procedure of ridge preservation. So preventing dry sockets, socket preservation grafting, very promising that, but we can also assist with osseointegration. So positive effects of platelet-rich fibrin in animal studies, for example, in rabbit tibia, placing implants with or without platelet-rich fibrin, you had faster bone healing, so faster integration in the rabbit. And then in another model, in mini pigs, we have an increase in the bone-to-implant contact, the mechanism of osseointegration. So at 4 weeks, bone-to-implant contact was 44% with PRF, whereas 20 or 30% without. And at 8 weeks, 70% bone implant contact with PRF versus more or less 50%. So it appears to be a benefit in the osseointegration of dental implants. So the way this is often done is that in this, similar to this study in humans done by Perper, the CGF or PRF clot is placed in the osteotomy versus not. Okay, this is a controlled clinical study, and they measured stability of the implants at 1 week and 4 weeks using resonance frequency. The test implants showed significantly higher stability at both time points. And even in the placement of immediate implants, you have this investigation where they were looking at the effect of leukocyte platelet-rich fibrin clots, LPRF, on immediate implant stability. So they looked at 60 immediate implants, a split mouth design, test implants with LPRF, controls not, and they showed significant differences in stability at 1 week and 1 month with immediate implants. Now, so here's an example of an immediate implant. The tooth is being extracted, replacing the implant immediately. The clinician is placing a PRF clot first, then introducing the implant, and then if there are any gaps left, using another CGF clot to fill the graft. Now this, and notice that this immediate implant was done with a flapless procedure, and there's no attempt to have wound closure. The CGF clot basically delays epithelial closure of the wound and allows bone formation to occur at the implant surface as opposed to a long epithelial attachment. So the CGF clots are very useful for filling peri-implant gaps with immediate implants. So here's, for example, a nice little case that was presented in Oral Health in 2014, where a maxillary molar is being extracted. They're using the furcal bone to stabilize, to begin the osteotomy. Then they're coating their implant in the AGF, autologous fibrin glue, and then they're using their sticky bone, basically, and using another CGF clot, spearing it onto a healing abutment, and basically sealing the wound with this clot, and even adding some more autologous fibrin glue over top of the sutures. So there's the, on the left at 10 days postoperatively, then at 3 months and the final restoration. Now I take this opportunity to show something from my own mouth, which was done a couple of years ago. I had a failed big root fracture on maxillary first molar, and basically an implant was placed immediately into the furcal bone, into the septal bone, sticky bone was applied around, and then CGF clots were basically used as a poncho to pull over the healing abutment and sutured. Okay, and the surgeon was one of our residents at the time who now practices in Ottawa. So here you see the immediate post-op with the particulates, the sticky bone graft, and here you see the implant after 18 months in function. So I certainly was pleased with that outcome. So the other thing is that because there's some antibacterial impact with PRF clots, the Italians, Del Fabbro and others, basically have suggested that we don't have to worry about chronic periapical infections if we're doing immediate implants. So basically in this situation, we're doing immediate implants where there were chronic periapical lesions. The PRF clot was placed in the socket first, and then the implant was coated with, as you see in the middle picture, with the liquid fibrinogen, and the implant then inserted. There were 61 implants. The result was very good at 18.5 months. So the next thing, a paper I just discovered this week, a paper by Schultz, in which they're suggesting that decontamination of peri-implantitis affected rough implant surfaces might be achieved with PRF clots. So for example, this was an in vitro study. They had SLA roughened, that's particle blasted, acid etched roughened discs, in which they introduced plaque organisms. And after a certain incubation period. Then the discs were rinsed with saline. The control discs basically were put into sterile medium, whereas the test discs received liquid that had been squeezed out of the LPRF clots. And the impact was significant. You see the control after the incubation period with the medium is full of bacteria, whereas the LPRF fluid killed off all the bugs. So that's an interesting concept too. It hasn't been investigated as yet with periimplantitis, but certainly seems to be an area for future investigation. And then the next use with CGF clots is as a membrane when you're doing bone augmentation. So again, work that's been done by my colleague, Professor Son, where we can create membranes by compressing them in a special stainless steel box. So we pull the clots out of the red cap tube, as you see here, and place it in the box, put the lid over top, and what we get are quite thin membranes, okay? Membranes, of course, which have a few stem cells, but are full of leukocytes and platelet-rich growth factors. So then we can cover that over a graft, as you see in this lower slide on the right. And of course, we do some suturing after that, but this acts as a biologic membrane. So it certainly reduces the cost of the surgery too, because you don't have to necessarily introduce something like a collagen membrane. So here we have also, this is from one of Dr. Son's preparations where he's placed an implant. We had a big dehiscence on the buccal. So we put sticky bone over the dehiscence, and then added some autologous fibrin glue as well from the yellow cap tubes, and then used a membrane, a flattened CGF clot as the biologic membrane. Now this is really interesting. This is again, Italians are very big in this field, in implant dentistry and in regenerative surgery. And this is from Cortellini. He's actually, you know that you can take autogenous blocks from the mandible, from the chin or the ramus area, and you can transplant them to other parts of the mouth in order to create more bone. Of course, it's a rather morbid procedure. It's a challenging procedure, comes with certain risks. Or you can buy blocks, either allograft blocks or xenograft blocks, such as BioOs blocks, from manufacturers. But Cortellini has introduced the idea of using the leukocyte and platelet-rich fibrin to make a block all on its own. So this is a single cohort study. He created blocks out of the LPRF fractions and then used superimposition of preoperative and postoperative CT scans to show significant horizontal bone gains in those patients of 4.6 millimeters at 2 millimeters below the crest. Okay, so that's almost 5 millimeters of width gain, which is quite remarkable. So in this case, they took their LPRF clots, they flattened them, and they took some liquid that had been squeezed out of the clots from the stainless steel box. They moistened BioOs with that, and then they took one or two of their clots, their LPRF clots, cut them up into small pieces, and mixed them in with this, with the BioOs and the fluid. And then, after they mixed it really well, they added the autologous fibrin glue and ended up with a block. Okay, and a block which will hold its shape. So, for example, we did this recently in our grad clinic. You can see that I was working with one of the residents. We held the block up, you know, we dropped it, it kept its shape, and so on. All right, so it's a great new introduction into creating autogenous blocks from the patient's own blood. So to review, Cortellini, he collected 6 tubes, red cap tubes, and 2 white capped or yellow cap tubes to get the autologous immediately after 3-minute centrifugation, withdrew the straw-colored fluid into a syringe, and then continued centrifugation to produce the LPRF clots. Then he chopped the clots into small pieces, mixed them 50-50 with BioOS, then added some autogenous fibrin glue, and that's the fibrinogen, liquid fibrinogen, and the whole thing formed a block. Now, these were the sample patients. You can see the great ridge deficiencies here, okay? He used his blocks. First of all, he used a collagen membrane, which he secured with pins. Then he laid in his block of graft material, and then he covered the whole thing over with a CGF flattened membrane. And so there you see the bilateral augmentation. This shows the pre-op, immediate post-op, and 5 to 8 month post-op to show you how much bone gain he was able to achieve, okay? As a mean, almost 5 millimeters of bone gain. So then when he went to place the implants, he has all this bone. And so it turns out to be a really nice way to, biologic way to regenerate bone using the patient's blood and a bone substitute like BioOS. Now, in Italy, allograft particle, particularly graft materials, are not available. They're not ethically approved, so they have to use BioOS. But this is a very nice result using BioOS or xenograft with the patient's own blood. And this was a paper from, okay, so I have to skip along here. They have substantial body to these clots, okay? I'm going to skip over that. Sinus grafting, we can use the clots for open sinus grafting, which reduces patient morbidity, but also we can use it for indirect sinus elevation, for using osteotomes, for example, or other means of placing an implant to lift the sinus floor by several millimeters. We can basically just use the clots as the graft and then insert our implants. Okay, so this is the pre-op. You see the original sinus floor was down here. You can see some cloudiness here. These were the CGF clots. But then by 1 year, you see a whole new sinus floor being formed. So excellent for grafting the sinus. And others have done similar things. You can even do, I'm going to skip over that because we're running out of time. Anyway, oral antral communications, most of them heal on their own, but you can certainly use a fibrin-rich, platelet-rich fibrin clot for that, suturing it to the surrounding soft tissues. And then soft tissue grafting. Okay, it's possible to use PRF clots rather than connective tissue from the patient's palate. But these are still being tested at the present time. But this is a really interesting case where we start out with a Miller class 1 type of lesion, recession lesion, and this is the result after using only platelet-rich fibrin clots plus a coronally advanced flap. And others have shown similar outcomes. The root coverage with the connective tissue graft and the platelet-rich fibrin clots, in both situations being used in conjunction with coronally advanced flaps, produce very good and similar root coverage, but complete root coverage is a little bit better with the connective tissue grafts. So there are a number of clinicians who've now been confirming that this kind of substitution for connective tissue graft does hold promise in the future. And certainly when there's a lot of, a number of adjacent teeth with recession, the PRF clots in conjunction with coronally advanced flaps may be a good way to go, even if you don't get complete root coverage. The protocol for doing soft tissue grafting is that you have to have enough keratinized tissue width to allow you to coronally advance a flap. Okay, you should have a thick gingival biotype. You should try to avoid papillae if you can, and do a combination partial full thickness flap, as Dr. Lai discussed last time, so that you can basically use some sutures to secure the CGF clots over recession defects. And you always use, it's been recommended by Shukran and others, that you fold them over the CGF clots or the PRF clots and insert as many as possible in order to increase the thickness of the grafted area. And then, of course, there's also lots of investigations looking into the use of CGF clots in periodontal regeneration, but that's a whole different topic. Just come back to this cosmetic improvements. There's a big push now, certainly in the US, with organizations like the American Academy of Facial Aesthetics, to get dentists involved in dealing with perioral and even non-perioral facial anti-aging treatments. So remember, there are some stem cells at the interface with the AGF, autologous fibrin glue, or fibrinogen's isolate. You can withdraw that, and then you can inject it in problem areas to stimulate collagen formation and basically, to a certain extent, reverse the signs of aging, both on the face and even on the hands. Remember, the hands give you away your age spots on the hands. They can be reversed with this kind of treatment. And hopefully, I'd like to see someday that dentists are doing, certainly dental specialists, but maybe dentists in general are doing these kinds of treatments in addition to the standard regenerative oral surgical procedures. This is another application where we're using a microneedling device, basically coating the face with the CGF, the AFG liquid fibrinogen, and then basically doing multiple puncture points to get penetration into the skin. So this is certainly for the future, but I thought it would be interesting for you to know. It's even been proposed that you can stimulate hair growth in both men and women. Although I must say I had it done several times, and because of my age, I guess it didn't really have any impact for me. So we've run over a little bit, I guess, but that would be my presentation for this evening. Platelet-rich plasma preparations. I'd like to think that in 20 years we'll look back and we'll say this was a major contribution to regenerative procedures, not only in dentistry, but in medical fields as well, in sports medicine, in diabetic ulcer management, and so on and so forth. So I think we'll look back in 20 years and say that this was a definite move forward in regenerative surgery. And with that, I'll say thank you for coming to the seminar, and I'd be happy to entertain any questions.
Thank you, Dr. DePorter. It was a great presentation. I'm sure everybody learned something tonight. And, you know, we've loved using the CGF and sticky bone in our clinic, and we're so happy to have you to guide us through the process. So with that, I'd like to open the floor to any questions. We have a few, and myself, my name is Alex. I'm one of the third-year perio residents at U of T, and along with a few of my colleagues will be asking some of the questions. So please direct them to the moderator. So Dr. DePorter, the first question is about the CGF membrane, and they're wondering how long the CGF membrane lasts in the mouth if left exposed in the case of a socket preservation procedure. And Do you know also comparatively how long it may last if you are able to get primary closure?
Yeah, the estimation for the time of survival for the clots is 10 days, 10 to 14 days, whether it's covered or not, whether you have primary closure or not. And over those 10 days or 14 days, most of those days, there'll be a slow release of growth factors. So you're not just hitting the wound with the growth factors at day one. It's spread over, unlike the first generation platelet-rich plasma, the platelet-rich fibrin clots continue to release growth factors for a significant period of time.
That's great. That's great to know. I hope that answered your question. And so, Ryan, you're up.
Hi, everyone. My name is Ryan Noah. I'm a second-year Peria resident. Thank you very much, Dr. DePorter, for such a great presentation. The second question I have for you today is, when using sticky bone, which bone substitute material do you recommend using? Xenografts, allografts, or autografts?
Well, it really depends on the purpose of your grafting. So, for example, if you want to have the graft last a long time in order to change the anatomy of the site, you probably use a xenograft. Whereas if you are using it, if you want to use it for in a socket or in an area where you want to correct a dehiscence or fenestration, you're probably better to use an allograft material, right? But it's totally up to you. Certainly, as I said earlier, in Europe, allografts are not ethically usable, and so people use xenografts for everything. But I think more or less in our graduate division, the residents would normally choose to use an allograft first before a xenograft. Is that helpful at all? Hello?
Yes, thank you very much.
Okay.
Boris?
Boris, you have to unmute yourself. Chris, can you unmute Boris?
Let me take a look.
I can go ahead with the third. Oh, does it work? Okay.
Yeah. So hi, everyone. My name is Boris, and I'm one of the first-year residents. So the next question we have for you, Dr. DePorter, is do you recommend using clots only for indirect sinus lift procedures, or would sticky bone be an option as well?
Well, you can do either. The nice thing about using only clots is that if you have a undetected sinus membrane tear, the clot will immediately repair that. The disadvantage with using only the clots is there'll be more shrinkage of your grafted area. So if you want to ensure that your implant apices remain in the long term, maintain the gain of bone, you'd probably be wise to use a combination of the two. So you could put one or two CGF clots in first to make sure that your sinus floor is intact, and then add your sticky bone. So either or, alone or both.
Great, thank you. The last question we have here is about the long-term follow-up studies. Is there any long-term follow-up studies on the stability of using the clots in root coverage procedures?
Okay, and the answer to that would be no, there aren't, because it's a relatively new procedure, right? And people are introducing it as a modified technique, but there hasn't been adequate time has not passed to verify that the results are stable over the long term. There's no reason to think they wouldn't be, but the data is not there.
Great. Okay, thank you so much for answering all the questions. That's all the questions that did come in this evening. I'm going to pass it over to Dr. Bide, who's going to be the one closing off the evening.
Thank you, Alex. And Doug, I have a question of my own here for you. What are some of the complications, if you will, or adverse reactions, if any, that you've encountered using PRF or CGF?
We've encountered no complications, but we have seen strange occurrences. For example, a patient who had a fatty meal and ends up with a cloudy small clot. We don't know if that clot's going to work or not. We don't know whether the patients who have been taking aspirin, even if they interrupt the aspirin for all, we don't know what's going to happen if that clot is going to be as good as someone who doesn't take aspirin. So there's an awful lot of questions to be answered still. And that's why I think that we do need the next decade at least, probably, to understand this innovation more thoroughly. Okay, to understand, for example, if a cohort study, a study is being done with CGF clots as opposed to non-CGF clots, how many of those patients were taking aspirin? How many of them had, been previous smokers? All these things could impact the outcome of the study. And so we're going to have to be very careful in patient population selection in the future, I think, in order to fully understand how these things work and what things will prevent them from working.
And have you ever had cases where you've done all the workup and drawn what you need to draw from the patient and just have come up with something that's unusable during a surgery?
Yes. Most likely it's because the blood draw was too slow.
Okay. And what percentage of times would you say that's happened to you?
10%, maybe.
Okay. Doug, thank you again for a very informative, outstanding presentation. I was commenting to some of my colleagues who've joined us from when I was a resident that we feel like we're residents again from listening to your lecture and learning stuff that we could apply in our practices the very next day. So very grateful. Thank you so much for taking the time today and giving us an outstanding lecture. And thank you to everyone who has taken time out of their busy schedule today to attend another OAK seminar with us. And we certainly hope you'll join us for the remaining seminars for the rest of this year. And we're busy working into finalizing speakers for 2021. Just a quick reminder that in 2 weeks at 6 p.m. Eastern, we'll be having Dr. Dan Cullum. Again, he's an oral surgeon from Idaho, and he'll be talking about a topic which is very interesting to me, which is the use of amnion-chorion membranes for various oral surgical applications. So until then, please stay safe, and we look forward to seeing you again in a couple of weeks. Thanks again, everybody. Good night.